to another edition of Professor Speaks. My name is Alex Hernandez. Alongside me, as always, is Dr. Craig Stern. And today we're going to be talking about diabetes. Now, before we get into the meat and potatoes of why we really want to talk about it, we're going to define a little bit between the two types of diabetes. There's type 1 and type 2. Can you help us with that?
Let's just quickly, since I was asked not to do a lot of the pathophysiology.
Without getting into the science into it. Yes.
There's type 1, used to be known as childhood diabetes, where people don't have the capability of producing insulin.
Right.
It's about 10% of the total population of diabetics. And then there's type 2, used to be known as adult onset diabetes, which has to deal with adults having a problem with their ability to control their blood sugar. They still are producing insulin endogenously from their body, but it's not in control, and so they need drugs and diet and exercise.
So you said used to. Why has it changed?
Because over time, the old concept of childhood and adult has been changed to really numbers and what the metrics are and when it occurred. And there have been people who now have what would be known as childhood obesity, childhood diabetes, that didn't have it as a child, but now have developed it when they're in their 20s.
Right.
So there is some crossover going on. It's still, for the general description, it still has some meaning, but it's not the way that it's described today.
So I guess it would be weird for an adult to tell someone that they've been diagnosed with child onset diabetes, right?
Well, that's true. However, we have had interns that have had that problem. So it is a surprise, and clinicians who were trained some time ago tend to think of it as childhood, and when someone says it's that, then there's a lot of questioning about what that means.
Right. I understand. How has diabetes impacted our population? I mean, we know just beforehand we've been talking about diabetes being more prevalent today than it has been in the past. We're trying to combat these. There's been the former First Lady talking about how to get students active and more active in schools, and trying to get adults to be more active, but we're still seeing that diabetes numbers rise. And can you give us some pointers as to how that is or why that is?
Yeah, and it's not just a U.S. phenomenon. Diabetes has been increasing all over the world, even in third world countries.
Right.
The major emphasis that people have placed has on diet and weight gain.
Right.
And there has been a significant increase in weight gain and obesity across the world, certainly in the United States as well. And the diet is significant in that processed foods and others contain a good deal of salt, contain a good deal of fat, contain a good deal of the things that lead to diabetes, and also as well hyperlipidemia or high cholesterol and high blood pressure. Just as an example, black people, there have been studies of black people who came from Africa, and there wasn't as high of a prevalence of diabetes in their country. When they came to the United States, they developed a greater prevalence of diabetes than they had in their own country.
Wow.
Typically due to diet and then increased weight and weight gain. So there are some comparisons. It isn't a matter of just picking it out among cultural issues because it's widespread, it's everywhere. But it gives us some balance to understand what's going on.
Wow, that's interesting. And there's really no one way to combat this issue, man.
Well, for the standpoint of people, number one is fundamentally you have to deal with weight loss. You have to. You have to deal with an appropriate diet, and you have to deal with appropriate exercise if you can. Those are fundamental. Even medications, you can throw all kinds of medications at people, but if they're not in control of that, then drugs are going to have more and more of a problem in trying to control diabetic problems if you don't do those. And today, the biggest issues is not just diabetes, it's diabetes and high cholesterol and hypertension, known as metabolic syndrome. So frequently it's not just one disease, it's multiple diseases, and all of those are affected by watching your diet, losing weight, and getting exercise. And by the way, they're all independent risk factors. Okay. So if you don't do it, they are risk factors to get diabetes,
right,
etc.
Right. So I'm just backtracking a little bit. There's also diabetes insipidus. Can you define that one for us?
Sure. Yeah. Well, we are not talking right now about diabetes insipidus.
Right.
Diabetes insipidus is a problem with salt control, and it has to deal with a different part of the body. It doesn't have to deal with the pancreas. So we're dealing with an entirely different diabetes. Most often when people talk about diabetes, they're talking about diabetes mellitus, not diabetes insipidus. So we just need to keep the two separate.
Okay. One of the major things with diabetes is not just how to avoid it, but also the cost of it, and that seems to be rising a lot.
It is.
And it's becoming more of a problem because, from what I've seen, the population that has the most diabetes is often the lower income of our population. So so when costs are rising, but the lower income people are the ones getting diabetes, I mean, there's a huge gap there, and it's a big factor for our population.
It is. It's huge. This may offend some people, but it's necessary for us to say. Diabetes and the American Diabetic Association and others have given a host of criteria in step therapy on drugs on how to treat it. Clearly, the first step is the weight loss, diet, and exercise.
Right.
But having said that, effectively, the world has kind of changed, and it's important for us to understand that. There is a way to handle diabetes and get it in control in general with less expensive medications. However, what happened was many of those medications went generic. Therefore, commercially, it was necessary from the manufacturer's standpoint to come up with branded drugs to replace those generics. The argument that they made, and they're correct arguments, the argument that they made is that those generics caused hypoglycemia or low blood sugar, frequently because people didn't dose it right or they didn't titrate it and monitor it right. But either way, that they had side effects in it. They also addressed the fact that many of the new drugs treat issues with regard to cardiovascular implications of diabetes and kidney complications. Well, what they've done is to create two populations of people within the world. One is those people that we could treat for comparatively less money and get them in control.
Okay.
And then the other people who could afford it are taking many of the newer drugs and getting them into control. The commercial interests have everybody thinking that there's only one population and only one way to treat it, when in fact there is more than one way to treat it. And so there is a way to help. What is working against that is that many of the insulin manufacturers have increased their prices of insulin, so it's made this particular lower cost way of doing it a bit more expensive, but it's also much less expensive than some of the other ways. So we have to, as the whole world works on transparency, trying to understand what things cost, we have to understand that part of this is being driven by commercial interests who want us to be using certain drugs, and they're right in many cases. But in other cases, you can treat many of these things. And by the way, it's not just true of diabetes, it's true of hypertension, of high blood pressure, and hyperlipidemia. You can treat them, probably 80% of the population, for a much lower cost. And then those people who really need it, they need many of these newer drugs.
So you had mentioned earlier when we were defining between the two type 1 and type 2 diabetes that type 1 accounts for about 20% of the population.
10.
Oh, 10%. Oh, even less. So the other 90% you could say would be preventable, right?
Well, it's not so much that it's preventable. Clearly, there is an opportunity to prevent a good deal of diabetes.
Right.
Or at least to know you're diabetic, but it's under control with diet and weight loss and exercise. So
Right.
there is a way of dealing with that.
Right.
But it's hard, right? I mean, losing weight is not an easy thing to do. And keeping it off is even harder.
I'm sure everyone at home can relate. Yeah.
But at the end of the day, prevention is important. It doesn't stop everything.
Right.
Certainly there's familial forms where people get it, either by genetics and family history, etc., where they have it. But certainly that can cut down significantly on drug use and the kind of drugs that you have to use to control it. And then there's a body of people that do need medications in addition to all of the other factors, and they need to be treated. And then there's another smaller population that's really sick that needs a lot of therapy and a lot of different stuff. Clearly, we're often an appeal or the last appeal in what goes on in those kind of cases. The good news is that population is relatively small.
Okay.
The major population is kind of in the middle. You can't control it entirely with weight loss and diet and exercise, and they require some sort of therapy. The more that people stay in control, stay in tight control with their prevention, stay in tight control with their medications and how they do it, then the better off they are, the better they feel, the better life that they have.
Yeah,
and less problems.
Yeah, and the better life without having to take drugs all the time or shooting an insulin needle or anything like that. But also, I wanted to bring this up. We got on this topic about diabetes from an article that we read about 2 weeks ago, 3 weeks ago, mentioning that there were doctors looking to change the risk guidelines. I mean, correct me if I'm wrong.
Yes.
The risk guidelines for how they're monitoring the blood glucose level.
Yes.
And it doesn't seem like that much. I mean, they went from 7 to about 7.5, 8, right? So, what impact would this have if they do change the guidelines for monitoring diabetes?
Well, you know, guidelines come out of national consensus committees.
Right.
And it is very common that every 5 years, 10 years, that the next consensus committee will change some of the metrics that says this is the diagnostic threshold, this is the number that people have to reach, etc. So there's nothing new about that. It happens in high blood pressure, it happens in cholesterol, it happens in diabetes, happens in BPH, benign prostatic hypertrophy, happens all over. The problem, the cause of concern is that the consensus committee took a look at a number called the A1C. And the A1C is a measure of how the insulin has uptake in the tissues.
Okay.
It doesn't happen instantaneously. It takes a while. And so this is done probably every 3 months or so to find out. And the last consensus committee had it where it was a very tight control, or what they thought was a very tight control. Typically, anything that was less than 7 when people were older, and certainly less than 6.5 or even down to 5.7 to try and get even stricter control. Now with the new criteria, they've increased that so that they're saying, well, you don't have to have it quite as tight control. You can have it less. Well, the argument that is being made is, one, it's different for people who are older, meaning over 50, over 65, than it is for a younger person,
right?
Adults. And that this number is allowing people to feel that they're in control when they should have been in tighter control. So the argument is a clinical one,
right,
as to whether you want really, really tight control or whether you want less control. There'll certainly be reviews of those guidelines, and doctors will have to make up their minds about it. Today, most doctors are trying to do tighter control, and they probably do a little bit less as people get older. But that's where the argument is. That's where they're going. And it is certainly an argument in diabetes, but by the way, it's also been an argument in multiple other diseases.
Right, and it seems strange that they would become more lax in their levels of, or their thresholds of control. Like, why would you want to allow a higher threshold? I mean, if anybody, if any profession you'd want to be strict, it would be your doctor.
Sure. I guess the part of the problem, and the study had multiple reasons, but let's be simplistic about it.
Okay.
Because people are gaining weight and are overweight or obese. Mm-hmm. It's harder to control if you can't get them to lose weight.
Okay.
Second is many people, a lot of people, are afraid of the needle. So they're afraid of insulin because they would have to test themselves every day and then have to give themselves a shot. Mm-hmm. So there is a social factor in this. And I believe that probably in a very general way, the consensus is moving to try and deal with that whole social process. One way or another, the population cannot continue to get bigger and bigger and bigger. The population is going to have to take some responsibility for losing weight.
Right.
They're going to have to take some responsibility for watching their diet. They're going to have to take some responsibility for getting some exercise. You cannot allow a population to just continue to get bigger and bigger and bigger. The complications in cardiovascular disease, in kidney disease, in cancer, the studies and the numbers just get bigger and bigger. And it's not for us to discuss every one of those right now. It's just to identify that being overweight and being obese is not a good thing.
Right. It seems weird that here we are, 2018, and in order to control the amount of people getting sick, we have to tell them to take responsibility for your health. It's
well,
like,
all of healthcare.
Where's the education coming from?
All of healthcare is moving to prevention because it's cheaper to prevent something from happening than treating it in the emergency room, treating acute care hospital, or even treating it at home with a bunch of drugs, etc. Everyone's moving to that. The problem is that it's not just a medical change, it's a social change.
Yeah.
And people need to pay attention to that. Certainly people's diet and the kind of things that they do today are different than they did when we were kids or younger.
Right.
And ate diets that were high in salt, high in fat, high in a host of things that overall was not good for us. But people learn and they learn and they learn. The hope now, though, is that just because the latest studies is that obesity is rising, but so is exercise rising,
right.
Which is kind of weird, right?
It is. It doesn't make any sense.
It doesn't make any sense, right?
Yeah.
But one way or another, you cannot allow the population to continue to get fatter and fatter and fatter. And just because you exercise, but then you go eat a lot, doesn't mean that somehow this is going to stop. So the population socially is going to have to be educated as much as medically to try and control this whole situation.
Right. Well, we've gone a lot longer than I thought we were going to go. But I hope you got some good information there from Dr. Craig Stern. And hopefully you'll come join us next week. And please visit ProPharmaConsultants.com. We have a free information page called RxInfoX. If you would like any more information on the topic we covered today, please feel free to message us. Or if you have a question about something else related to healthcare, please feel free to message us. And we'd like to get to that right away. Yeah, that's all for today, and we will see you next week.
If you like the video, hit the subscribe button.